Hi, I'd like to welcome you to the self-evaluation episode of the ASCO University weekly podcast. My name is Arun Singh, and I'm the co-clinical director of the UCLA Sarcoma Clinic and an assistant professor in the Division of Hematology and Oncology at UCLA. Today we feature a self-evaluation question on the treatment of sarcomas. I'll begin by reading the question stem. Briefly, a 67-year-old woman presents to her breast surgeon after having noticed a growing lesion in the site of a prior breast cancer. About 11 years ago, she underwent lumpectomy for a 2.3 centimeter invasive ductal adenocarcinoma that was ER/PR positive, HER2 neu negative, and node negative. She received adjuvant chemotherapy using doxorubicin, cyclophosphamide, and docetaxel, followed by radiation to the breast. She completed her hormonal treatment about 6 months ago. Her family history is also significant for an aunt with breast cancer at age 75, and her social history was non-contributory. On exam, there's a nodular flesh-colored mass with purple discoloration measuring 4.8 centimeters in largest dimension. A biopsy performed in the office was consistent with a high-grade spindle cell neoplasm with well-formed vascular channels lined by atypical endothelial cells with pleomorphic hyperchromatic nuclei, and the immunohistochemistry was positive for vimentin, CD31, CD34, and factor VIII, but negative for melon A. What is the most likely etiology of her new malignancy? The answer choices are A. Anthracycline exposure, B. Prior breast irradiation, C. Taxane exposure, D. Stopping hormonal therapy, or E. A family history of cancer. The correct answer to this question is answer choice B. Sarcomas are a rare group of bone and soft tissue malignancies, and there are approximately 100 subtypes of sarcomas. There are few known etiologic factors associated with sarcoma development. Of the answer choices, only prior breast irradiation has been associated with the development of sarcomas. In this instance, this would be considered a radiation-associated angiosarcoma. The long latency between the development of the sarcoma and the delivery of radiation therapy and the development of a sarcoma within the radiation field is what is classically seen for a radiation-associated sarcoma. In fact, the median time to radiation-associated angiosarcoma development is about 7.5 years, and in this patient's case, it was 11 years. In this case, the patient developed a vascular tumor as evidenced by the positivity of CD31 and factor VIII, which makes this an angiosarcoma. But in fact, several different types of sarcoma histologies have been described in the setting of a radiation-associated sarcoma. While one can argue that there is such a thing as de novo angiosarcoma of the breast, and that it is impossible to histologically discern these two entities, in fact, de novo radiation-associated angiosarcoma is usually seen in younger women. One should note that the diagnosis of a radiation-associated sarcoma is a clinical diagnosis, as a radiation-associated sarcomas is less than 0.1% in radiated fields, and studies of the etiology of this type of sarcoma are based on retrospective analyses. The rationale for the wrong choices. The other choices are incorrect as they have not been associated with sarcoma development. Anthracyclines have been associated with secondary hematologic malignancies, but not sarcomas. Taxanes and hormonal manipulations have not been associated with angiosarcomas or other sarcomas. Patients with the Li-Fraumeni syndrome, which is characterized by tree loss via various mechanisms, have been noted to develop sarcomas at a higher rate than p53 wild-type patients. However, the family history presented here does not support this conclusion. Thank you for listening to this week's episode of ASCO University's weekly podcast. For more information on the treatment of sarcomas, including opportunities for self-evaluation, please visit the Comprehensive e-Learning Center at university.asco.org. Thank you.